Hello, my name is Ash Oganesi, and today I'll be talking about ankle arthroscopy complications. So what is ankle arthroscopy? Ankle arthroscopy is a minimally invasive surgery used to treat certain problems in the ankle joint. Like in any other part of the body, arthroscopy is used in. In ankle arthroscopy, you're using a very tiny camera at the end of a fiber wire to to put that's inserted into the ankle joint through specific mapped out openings. Now these openings, they're incisions, and they're called portals. And there's 5 main portals. There's the anteromedial, anterolateral, anterocentral, posterior lateral, and posterior medial. Each of these portals has its own indications and its own risks and complications. That's beyond the scope of this presentation. Ankle arthroscopy is becoming very popular because there's reports of faster healing time and earlier mobilization, and it's a better cosmetic outcome, which a lot of patients are really looking for. But a lot of surgeons are not convinced because there's potential complications to ankle arthroscopy which are not present during other procedures, and it's believed that arthroscopy is just it could be a waste of time and money and resources when compared to standard open procedure techniques that a lot of the surgeons that have been working for a while are used to and are practicing a lot. So the indications for ankle arthroscopy there are many. The major ones include osteochondral lesions of the talus, microfracture of the OCD, debridement of the post-traumatic synovitis, ATFL, anterolateral impingement, resection of spurs, ostriginum excision, removal of loose bodies, and cartilage debridement, just to name some. So ankle arthroscopy, there are a lot of indications, but it's also important to understand that most if not all of these issues can be taken care of with your practical open technique, surgical techniques, that everybody's used to doing without the scopes. And they have good results and minimal complications. So does ankle arthroscopy add an extra layer of complications and some extra things that surgeons just don't want to deal with? And that's what's important to see. And so we have to assess the risk of these complications and what complications are actually involved in these surgeries. Basically, studies have found that ankle complications are around 10% for when it comes to ankle arthroscopies. That is a pretty high number when you're considering that these are usually reviewed and regarded as safer surgeries, and you're also taking into consideration that you don't have to do these surgeries. These are sort of just a technique that you could do the old school open techniques that there's a ton of research on and have been done way more than the arthroscopic techniques. So the 10% is a high number, but because there's a really high demand for these procedures nowadays. When patients do research, they hear, oh, there's less scarring and cosmetically more pleasing, and they can get on their feet faster, so patients want these. And surgeons, it's good for them to do these because it's regarded as it's a skill set that you can have as a surgeon, that if you're doing these scopes or arthroscopic procedures, then you know what you're doing, and you build it's like other surgeons can appreciate the fact that you have the skill set. So a lot of surgeons are trying to actually do these and implement these, but I think, and what research shows is that we really need to, there's a specific group of people that these surgeries can be worked on. Not everybody's a candidate for arthroscopic procedure, again, due to the complications and risks that, the open procedures don't involve. Now the actual complications involved, there are a few. Misdiagnoses, wrong extremities, tourniquets being on too long and tourniquet damage, neurovascular damage is the major one that's is a very, very big problem. Tendon damage, infections is another big one, hemarthrosis and RSD, and even compartment syndrome. Now some of these are a little more rare than the others, but they have all been described in the literature, with neurovascular damage being the highest one. The areas of complication that we'll go through with are through the stages. There's the planning stage, there's the preoperative procedures that complications can arise there. There's the actual in-surgery surprises that you might encounter, and post-operative complications. So pre-operative planning, there's two important factors here that you need to take into consideration to try to avoid complications. You have to take a good history, because the more prepared you are, and planning in general, you have to do good planning. And with planning, the two major aspects are history and imaging. So you have to be able to do a good job with both of these to kind of know what you're getting yourself into. So with history, you kind of have a good picture of what the injury is, how it happened, what's involved. Are you going to be dealing with bone? Are you expecting to have tendon damage? Where are you expecting to be located in the ankle anatomically? So these are all things that you could actually get from a good history. And then the next step would be to take good imaging. So the imaging that is used most often is the MRI and the CT. They give really good images and results for the ankle and to see what's going on before you actually start surgery, so you could actually know what you're getting yourself into. What's important with imaging is that you as a surgeon want to actually take a look at the imaging pictures and videos and see for yourself what's going on, and not just take the word of the radiologist and their report. A lot of times, you know what you're looking for, and they will miss things that you probably wouldn't. So it's important to look at your own things, and if you have good imaging and you have a good history, you have a good idea, and you're safer, you're more confident when you're approaching the actual surgery itself. Now, for the preoperative procedures, things can also go wrong here. Actually, one of the biggest things that could go wrong is actually in this stage of the surgery. So preoperatively, positioning your patient is super important. You want to position a patient where you won't cause any nerve damage and where you will have the greatest field possible to work in. Tourniquet application is another one that sometimes causes some problems. You don't want a tourniquet on too tight, you don't want it on too long. This can again cause vascular damage, it can cause neurological damage. And then proper ankle distractions. This is a big one when it comes to arthroscopy, because with arthroscopy, the whole point is you have to distract the ankle to have space to work in the joint. With distraction, it's come a long way, and it used to be way more complications. Biggest complication with distraction is nerve damage, because you're distracting for a long time, you're putting tension on those nerves and vasculature and soft tissue, and then nerves get damaged. Nerves don't really heal, so it's really important to kind of do your best to either not distract or minimally distract. Before, they used to use pulleys and cranks attached to walls, and that was complications with nerves were high back then. Now we use the dorsiflexory method. It's a good one. There's some studies on that where you don't need to use any pulleys or cranks, and you put a foot in the dorsiflex position. That gives you some access to the portals and to the ankle joint, and then the physician can manually apply the traction as he or she sees fit. Surgical surprises, when you're actually in there, a lot of times with the scope, you're looking at things and there's unexpected things. For example, you could find an unexpected osteochondral lesion. There could be a size difference where you thought something was one size and then you get in and the lesion is bigger. And we all know that 1.5 centimeters is that cutoff between bad and really bad for the osteochondral lesions, and your approach to how you're going to treat them. So, if you thought the lesion was smaller and then you get in there, it's bigger, that's a surprise. Now that's going to put more time into your surgery. Are you going to back out of this procedure and then come back later, or what are you going to do? This is all complications. The location, did you map the location correctly from the imaging? Might be a different pathology altogether. And then too much bleeding, that's the hemarthrosis, the blood in the joint, that's a big complication. You don't want to deal with that it's painful for the patient. The blood fills into the joint, you got to do another procedure to drain the joint, so that's never a good thing. Let's see. And then complications post-surgery, we kind of went over these, but the three major ones are the hemarthrosis, the infection, and by far the most common one is nerve damage. And, we have to do things, if we want to do these arthroscopic procedures, to minimize, to minimize these complications, because these can be very dangerous. You know, nerve damage, you know, you don't recover from that. And then the neuropraxia, as it's called, and the actual nerves that are involved most commonly are superficial dorsal-cutaneous, saphenous, sural nerve can be involved, and you know, they can be involved whether the physician or doctor is in there with the scopes and he doesn't notice, or actually during the incision made for the portals, especially if there's abnormal anatomy going on, and you know, the surgeon thinks that the nerve is going to be here because it's always there, and then he goes in and there's an abnormality, and the nerve isn't where he thought it was going to be. So there's a lot of room for improvement with arthroscopy, and there are some things that, you know, we can do to head in the right direction and to get better learning. Arthroscopy in general is a skill set that needs to be learned and that needs to be perfected. It is difficult and has a learning curve which must be overcome, and new surgeons is not recommended for them to be doing arthroscopic procedures until they have trained and learned. And that's where the next step comes in. Practice is crucial. You know, to become proficient or advanced in arthroscopy, you need to practice. And there's labs and seminars, and there's a lot of opportunities these days for physicians to get that practice, especially because arthroscopy is such a growing field, and because patients want it more and more, and surgeons want to do it more and more. Now, another big issue here is improving the tools themselves, you know, the scopes and the tools needed to do the procedure. A lot of times, physicians nowadays, or surgeons, they're using scopes and other tools intended for arthroscopy in the knee or the shoulder, you know, because specific ankle joint tools haven't been made yet, or haven't been perfected. And I think if the technology is lacking, so will the results for these procedures. So it's important for good tools to be made and be used by the surgeons doing these procedures for the ankles. And finally, you know, picking the right patient. I think, you know, that can eliminate a lot of complications if you just, you know, kind of sometimes, you know, swallow your ego, or you do, you know, you look into it more deeply and you try to understand, is it really worth for this patient to have the arthroscopic procedure? Just because we can do something doesn't mean, you know, we should do it. And yeah, arthroscopy could look good, but not always end up good. And if for a surgery, it's not a have-to surgery, there are other techniques, maybe other techniques should be looked at. But arthroscopy does have a bright future, and of course, something less invasive and quicker healing. It's always a good thing, and always worth doing more research on and going forward to.